So welcome everybody to the second webinar in the ESOT series on the COVID-19 pandemic. My name is Luca Segantini. I'm the ESOT CEO, and I'm very happy to welcome you here and introduce our two chairs. Before I do that, I'll give you just a very short practical note about the Q&A session, which I know it's something very interesting for all the participants. Since we have about 300 people online at the moment, we cannot, of course, allow microphones. So all the microphones are on mute at the moment. But during the Q&A session at the end of the webinar, we will have 10 minutes where you will be able to submit questions if you wish. And that can happen in two ways. You can either raise your hand by using the button you have in the GoToWebinar interface. And your hand will be shown to the moderators and the chairs, and they will be able to see you and unmute your microphone and mention your name so you can ask your question by speaking it out. The second way is to type your question in the questions type box, which is immediately underneath, and all the questions will be logged there. And once again, the moderators will be able to see them and select a few questions to be submitted to our panelists. That's all I wanted to say. Once again, a very warm welcome. And now I'll hand over to our two chairs, Irene Bellini from Belfast, sorry, and Lucrezia Furian from Padua. Thanks a lot.
Thank you, Luca, and thank you all again for finding timing and joining today's webinar. I'm a renal transplant surgeon at Belfast City Hospital in the UK, and I am also the Transplant Live coordinator. During these challenging times of social distancing, we are experiencing the value of social media and web-based connections to keep our daily activities going on, from smart working to telemedicine to test track in our mobile phones and to e-learning. In this very context, I would like indeed to emphasize the opportunity that Transplant Live, the ESOT e-learning platform, offers. Two of our speakers from today have been already heavily involved, and I hope many of you will join us too, because as you can see, this platform that is in constant evolution will keep us up to date with the latest innovation in transplantation. For example, there is a dedicated forum and discussion board of COVID-19, where relevant material is freely available on demand to healthcare professionals to facilitate collaboration, exchange, and interaction beyond one institution reach. And where this webinar series we are developing, thanks to an unrestricted grant from Chiesi, is hosted too. Last time, on the 6th of April, we have covered the issue of imposed lockdown. We now are progressively moving towards the lockdown ease. Today, I think in Italy it has been already lifted. So different countries are facing different phases of the reopening. And without any further delay, I would like to leave the floor to my co-chair, Professor Lucrezia Furian, a renal transplant surgeon from Padua, Italy, who will just talk through the next phases. Thank you.
Thank you very much, Irene, for introducing me. Welcome to everybody and good afternoon. I think that we are all keen to start listening to our four terrific speakers today, coming from different parts of Europe. They will share with us their experience. We will have Stefan Schneeberger, Eric Rondeau, Jean Forsythe, and Giuseppe Feltrin. The first speaker I'm very pleased to introduce is Stefan Schneeberger. He's the head of the Transplant and Hepatobiliary Surgery at the Department of Visceral Transplant and Thoracic Surgery at Innsbruck Medical University. He has also been past president of ESOT. And thank you very much, Stefan. Please.
Thank you, Lucrezia. Thank you, Maria. It's a privilege to join this webinar and start with the viewpoint of a country that maybe was less severely affected by the COVID-19 outbreak, but just as much affected by the collateral damage. So no relevant conflicts of interest for this presentation. If we can move on to the first slide, please. As indicated by this graphic, Austria hit a short peak of COVID-19 infections, but then quite a rapid downturn of the new infections compared to the surrounding countries. Bear in mind that you have to, of course, multiply the numbers by 10, of course, if you want to compare the Austrian numbers with the German numbers, and then with 6 or 7 if you want to compare them to Italy or Spain. But it's fair to conclude that the outbreak was a lot milder than in the neighboring countries. This is also true if we look at the excess mortality, an interesting viewpoint to look at these data. If we look at the excess mortality of all of Europe, you see quite a significant peak, caused by COVID-19. And then again, if we look at the countries that were affected more severely than others, you see that Spain also did show quite a significant excess mortality, whereas other countries such as Austria did not show any excess mortality at all. The changes in Austria, the people affected, if you look at the age rate, were similar to other regions in Europe, so it was mostly the older population. But more interestingly, the geographic distribution, as shown in the next graphic, was very incoherent, with the majority of the people being infected in the western part of Austria. As shown on the next slide, the reason for this is that the places where it was first detected were the skiing resorts. And as you know, in the western part of Austria, many hundreds and thousands of people gather for skiing during the winter season. It's not so much the skiing slopes, we believe, where it was spread, but it's rather the part after skiing, what is referred to as après ski, where the virus was spread. And if any of you ever participated in an après ski, you know that it's, well, the exact opposite probably of social distancing. In fact, you can find everything there except social distancing, probably. So from there, the infection spread throughout Austria, but mostly also throughout the central parts of Europe. Something not to be very proud of, but that is probably one of the many sources where the virus spread in our country and beyond. The response of the government were quite rapid after the first 2 cases were detected in a hotel in Innsbruck. The chancellor proposed social distancing. Only about 2 weeks later, the actual quarantine was put in place, first in the hotspot and then a nationwide quarantine. Just before that, schools and bars and restaurants were closed. The reason for this being well adhered to may or may not be the approval ratings of our chancellor. He's a 33-year-old, so a relatively young chancellor who has approval ratings of above 70%. You may or may not agree with his political agenda, but the approval ratings indicate that people tend to follow when the government calls for something. It's interesting to look at the mobility and the surgery that is from our region. So you see the red dotted line that would indicate the date where the quarantine was announced. But the actual decline in the number of surgeries that were happened before this. So when the first requests for social distancing were made. And it's interesting to see on this and the next graphic that the number of surgeries correlates most closely to the mobility data. So these are data from cell phone tracking, and they were correlated with the number of surgeries that were done in our region. So it's not the exact time point when the quarantine was announced, but it's actually before that. So social distancing happened much before that, and it correlates very much with the amount of surgeries that we were doing before the resources were also reallocated. And this is true for weekday surgeries and for all-day surgeries. And on the next slide, we'll see that it's actually also true for acute surgical indications such as abscesses and appendicitis. So we see a sharp decline in these cases during this period of time. And again, it correlates very well with the mobility of the people in the region. Next slide, please. So with respect to transplantation, we only put kidney and pancreas transplantation on hold for about 3 weeks. Liver and heart transplantation, we did not close down, and lung transplantations were done in a case-by-case decision approach. The donor numbers actually affected our doings very much. We see a 70% decline in the donor rates in Austria over this period of time. And this is the actual collateral damage that hits us most, the decline in deceased donors. Next slide. We did the assessment of the surgeries that we did in our center during this period of time, and we see a sharp decline in the number of surgeries altogether, but also in the number of kidney transplantations, liver transplantations, and pancreas transplantations, despite the fact that we never closed down our liver transplant program. So this is related most probably to the sharp decrease in the organs available. One thing that we did to counteract this effect, because in the beginning it was very difficult to get the COVID tests in time in order to perform the surgeries, we heavily used normothermic machine perfusions in both liver and kidney, the hyperthermic machine perfusion, to extend preservation times in order for us to receive the COVID tests in time. And with normothermic liver machine perfusion, together with the cold transportation time, we can now extend preservation time to 38 to 40 hours, and that helps in respect of the current problems of awaiting the COVID tests for both donor and recipient. Next slide, please. So the current plan to reopen the country is ongoing. In early April already, building and construction work was reinitiated, followed by shops reopening on April 14. On May 1st, schools reopen, outdoor sports sites reopen, social gatherings are allowed again. On May 14, hotels and restaurants will reopen, and schools will reopen entirely. End of May, even public pools will reopen. We continue to wear masks, and social distancing measures remain suggested by the government. Next slide, please. With respect to transplant, again, current kidney transplantation was reinitiated. We selected low-risk cases at first. Live donor kidney transplant cases started on April 23. Starting with May 16, we'll have no further restrictions. Also with higher risk kidney transplant cases receiving a depletion and induction therapy. Our transplant ICU care unit continues to serve as a backup for the non-transplant ICU non-COVID patients, so that is impacting our resources. The Ministry of Health has suggested and promised initiatives to stimulate organ donation, and we continue to have mostly TCs also within our department and maintain to practice social distancing. Next slide, please. So that's the end of my presentation. I hope it was helpful to provide also maybe a more optimistic viewpoint from a country that was less much affected than our neighboring countries. Thank you very much for your attention.
Thank you very much, Stefan, and congratulations on the way you have managed your program. But still, I have a question for you. What would you change in your COVID-19 transplant program management if you would have the chance and the opportunity to turn back time?
I think that's an important question, I guess, for all of us. Of course, retrospectively, the measures that we have taken, especially with respect to the resources of the intensive care units, were beyond what was required. So at any point in time, only 25% of the intensive care unit beds were filled with COVID patients. If that would hit us again in a second wave, certainly the resources, especially intensive care resources, but also surgical resources, would not be allocated to the same extent to prevent for a major outbreak. I believe, especially at this point, because we know by social measures how to eventually get control of a virus outbreak.
Great, thank you very much. And I think we are all somehow dreaming about the after-scheme activities in Austria.
Thank you.
Yes, so we move on now to the next talk. Stefan has already talked about kidney transplantation, but I'd like to introduce now Eric Rondeau from Hôpital Tenon in Sorbonne, Paris, who will talk about chronic kidney disease and COVID-19, whether transplant or dialysis.
Thank you very much. Thank you very much for this introduction. Yes, I will talk about the idea whether it's better to be transplant or dialyzed during COVID-19. Next slide, please. I have no conflict of interest with this presentation. And no, okay, next slide. So first, I would like to start with a very simple question. To the audience. So it's a poll and you can answer. And the question is, the best survival during COVID-19 infection is observed in, you select kidney transplanted patients, or you select chronic dialysis patients. You will have some seconds to answer. Okay, thank you. So 73% said kidney transplanted patients, and 27 said chronic dialysis patients. So I want to take the opportunity to speak about the experience in France and compare it to the literature. We all know that the death rate during COVID-19 varies by age, health condition and comorbidities, and sex. And this was said by previous studies, and especially from China. And you can see that the death rate increased with age, especially after 80 years old, but also with the cardiovascular disease, increased mortality, diabetes, respiratory disease, hypertension, as compared to patients with known comorbidities. And also it appears that male patients may be more prone to have COVID-19, SARS-CoV-2 infection as compared to female, but also have an increased mortality. What about chronic kidney disease, and especially in transplanted patient or dialysis patient? Here is a map of France, where you can see two areas where there was a lot of infection, especially in the east part, in Alsace, but also in Ile-de-France. Here is Paris, and it is where I work, and I want to share with you our experience. Next slide. So in my hospital, we had 746 patients who were infected. And as a whole, 114, when we closed the analysis, that were dead. So it's a 15% rate of death. Among all these patients, we had 92 patients who went to the ICU, and among them, 24% died of this infection. Next slide. Among the dialysis patients in the same hospital during the same time, we observed 39 cases in the dialysis patient. The mean age was 61 years old, and they were from a cohort of patients who were dialyzed in the hospital, and 12 of them out of 112, that is almost 11%, were dialyzed in the hospital. So it's a quite high incidence in this dialysis center, as compared to only one patient out of 50 who were on dialysis at home. So clearly there is a difference of incidence between the two types of dialysis. 26 patients came from private centers. Importantly, 6 cases were managed at home, and 33 needed to be in the hospital. 9 went to the ICU, and the death rate was 9 cases, that is 23% of these patients. But it has to be mentioned that 7 of them were not admitted to the ICU due to comorbidities, age, and also because there was an overwhelming number of patients during these times. The mean age of this patient who died was almost 70 years versus 60 years for those who survived. Next slide. When we go to the registry, the French Registry, which include almost 50,000 patients on dialysis, we can see that 3% of the total had the infection, and among them, almost 70% died. So that is 253 out of this cohort. And when we compare those who died and those who remain alive, we see that the big difference was the age, 78 years old as compared to 70 here. And also we found that the comorbidities were different. The respiratory disease, the arteritis, the ischemic heart disease, and there was no difference for diabetes, similar percentage in the two cohorts, but surprisingly, there were more obesity in the cohort of dialysis patients who survived as compared to those who did not survive. Next slide. Concerning the incidence, we observe it's quite similar to that one reported in the Chinese center during the COVID epidemic, with a 16% infection in this cohort of patients on dialysis. And the death rate was also very comparable to 15%. Next slide. Concerning the transplanted patient in our cohort, during the same time, it was 44 cases out of 923. So it's an incidence quite lower than in dialysis patient in the center, 4.7%. Mainly younger patient with 59-year-old. And some of them were also treated at home with a remote surveillance, and 36 need to be in the hospital. 10 went to the ICU. There was withdrawal of antimetabolites and lower CNI targets that were used, and some cocktail of antibiotics or antiviral drugs, and in the inflammatory phase, some methylprednisolone. The death rate was 6.8% of the total of the cohort, but 8.3% of hospitalized patients. And again, those who die were not admitted to the ICU due to the age and also to comorbidities, and again, of the overwhelming number of patients in the ICU. So next slide. If we look at the registry in France at the same date, it's about 43,000 patients. 465 were declared to have infection, 60 died. That is a mortality rate of almost 13%. It was quite similar in liver transplantation and in patients who had heart transplant. Next slide. When we compare to the literature, we see that these percentage vary. In Italy, it was 25 death rate in transplanted patient. It was 7% in Colombia. It was 28% in the patient in New York in Montefiore Institute. So clearly, the number are very variable according to the center. Next slide. I will not speak about this Chinese paper because the origin of the organ was not mentioned. And according to the Declaration of Istanbul, we should not talk about these papers. Next slide. So in conclusion, in our center, the death rate for dialysis patient was 25%, for transplanted patient 8.8%, and for the total hospitalized population 15%. It's probably better to have a kidney transplant than to be on chronic dialysis. There is a lower incidence of COVID-19 infection and a lower morbidity, as we can see, at least in our center. I thank you for your attention. But before, next question. So again, if we go to this question, do you have any answer to provide? Okay, maybe it's over. Yeah, so the vast majority say that it's better to have a kidney transplant. Okay, I thank you for your attention.
Thank you very much, Eric. This was really interesting. I have a question, a very brief one. How would you justify to an obese elderly kidney transplant candidate his increased risk for being transplanted during COVID-19? Is adopting an age or BMI cutoff discriminatory in this particular situation?
Yeah, it's not an easy question, but I think that age is a risk factor, but it's always a risk factor during COVID-19 and without COVID-19. So we take the risk when we list patients who are more than 70 or 75. And concerning the BMI, it's not evident that this is a risk factor. It was not mentioned in the very large studies performed in China, and it was not mentioned in any analysis of comorbidities that recently were published in the New England Journal of Medicine. So I would be very careful with the BMI. And in our experience and in the French Registry, there were less obesity in those who die on dialysis than in those who do not die with COVID-19. So take care of this. And I think, yes, it would be discriminatory to choose the recipients according to age and BMI. It depends, of course, also of the graft which is proposed.
Thank you.
Thank you.
The next speaker is John Forsythe, Medical Director for Organ Donation and Transplant, part of NHS Blood and Transplant. He's a professor and consultant transplant surgeon at the Royal Infirmary in Edinburgh, UK. He has served as a past president of ESOT and the BTS. It's my pleasure to introduce John Forsythe, who will talk about how to effectively manage non-COVID-19 patients and provide the life-saving care needed. Thank you.
Thank you very much indeed. Thank you for the invitation to be part of this webinar. In the talk in the next few minutes, I'm going to cover the background in the UK to give you a flavour from the UK, how we dismantled the system over the last number of weeks as the pandemic hit the UK. And then focus on the recovery document that we have provided in the last little while, and a look to how we might then rebuild across the UK. I'd like to acknowledge, if I may, my colleagues Chris Callahan in Guy's Hospital and Dale Gardner from Nottingham, who have been very important in these slides and in building the service. So this is the picture in the UK in the last number of years, with the number of donors increasing, as you see in the blue bars, the number of transplants in the red bars, and the waiting list coming down. A good news story. Next, please. By 31st of January, we were predicted to, by the end of the financial year, actually still be better. But of course, COVID then hit, and you will see the effect that there was both on donation and transplantation. Next, please. Next, please. And the background to this is ICU data in the UK and pretty up-to-date ICU data, and you'll see the number of cases peak across ICUs in our country, and then begin to decline once again. So that's the background, and that's where we are at the moment. Next, please. And what effect did that have on donation and transplantation? Similar to some of the other slides that you have seen, the fact that donors and there's some effect there, but essentially the number of donors, the number of retrievals reducing. And we actually introduced criteria to try and focus us down on the donors that were likely to result in organ transplantation. And you'll see that changed our normal 1.5 to 1 ratio of DBD to DCD to a 3 to 1 ratio. So obviously a concentration on DBD donation. Next slide, please. So that resulted in, you'll see across the country, a significant suspension in kidney transplant units, in the pancreas transplant units across the UK, complete suspension. But the other units we managed to keep open for highly urgent and super urgent transplants. The reasons for those centres closing, next slide, were, as noted here, lots of different reasons, but actually the segregation of COVID positive and negative patients, or the inability to segregate those patients, was one of the major reasons stated. Next slide, please. What are some of the things we did, therefore? Well, two things listed here. First of all, early on, we put in place a registry of either waiting list, potential transplant patients, or transplant patients who had contracted COVID. And that is well kept up to date by the clinicians across the UK. And secondly, down in that left-hand corner, we also developed guidance for clinicians as to what information they should give to clinicians, to their patients at the time of possible transplantation. And again, thanks to Chris Callahan for his involvement in that. Then, of course, there is the aspect of excluding COVID from the deceased donor. Next, please. And we started with a screening by SNODs and obviously the testing, and we laid down the testing that was required. And you can see the guidance here in terms of actually taking the tests, which of course gives a variability otherwise. Next, please. And although these are Dale Gardner's slides, and he pointed out that as far as he was concerned, there was no added advantage to BAL. Next slide, please. And regarding CT scanning, whilst it has a high sensitivity, there are a lot of false negatives in the asymptomatic patient. And therefore, it's concluded that radiology for screening of asymptomatic patients, and I underline that, is not very successful at the moment. So therefore, that was particularly about the donor testing, and I'll come back to that in a minute if I may. So what are the things that we have done to try to build up and to guide and to support transplant units as they either extend or open? And I'll point you to this. There's the website on the top there, and we have, next slide please, the guidance for the reopening of transplant centres. A document, a quite comprehensive document, which I'll go into in more detail in a moment. Next, please. And it is quite a wide-ranging policy, and if anyone wants to access that, then feel free to do so. Obviously, it's written in a UK context, but hopefully valuable for all. Next, please. So what did we look at as the principles as far as this was concerned? First, we said, well, it's a local decision as to whether or not you want to open up the program. And that's because you have to look at your local resources and your local profile of COVID. Across the UK, the profile varies greatly. And we also feel that it's likely a phased reopening with different groups of patients, if you like, reactivated on the lists. Next, please. And we also felt that that is something that needed to be reviewed. Next slide, please. The other thing we didn't want to have was transplant units that were stuttering, opening one day and closing the next. What we wanted to do was to try to get units that were confident in staying open for a period of time. Next slide, please. And the approach was overarching in the document. If you access that document, you will see that it was across all organs. Next, please. But there was, in addition, building on the, if you like, the foundation of the overarching document, there was also organ-specific advice available. We also provided further virological advice, and I'll go into that in a moment, so thanks to those colleagues, and an aid memoir to consider the actions that need to be taken. Next slide, please. What did we say? We said that, first of all, there should be virological considerations for deceased donors. I refer to my previous discussions in the slides regarding the testing of donors. Obviously, a positive test, next please, a positive test in a donor was a suggestion should not proceed. Next, please. And we remind the staff across the UK that there is no reported donor-derived transmission thus far that has confidently been reported. But what about potential donors that have recovered from COVID-19? Well, following a number of other centres, we are saying that if more than 28 days have passed from the last COVID-related symptoms, then it is acceptable to consider donation. And if it's less than 28 days, there should be a case-by-case discussion. Next, please. Now to the recipients. We talk about screening within the document, screening for symptoms, of course, within the patients when admitted, but also asymptomatic patients. And we follow the same sort of testing regimen as I've given before. And there's discussion about whether you should always wait for the test to come back before you carry on with the transplant or not, depending on the urgency of transplantation and the type of transplant. And I refer you again to the discussion about the CT of patients admitted for recipient testing. I refer you to the discussion that I previously had about the dubiety around that testing. And then also we address the issue of should patients who have perhaps had COVID testing and be positive, should they then return to the list? And that's addressed in the document as well. Next, please. So where to from here? We encourage, with all of the documents that I've said to you put in place, that each unit should consider its own situation and build from there. We obviously want them to stay closely in contact with us so that we can make sure allocation decisions are made across the nation. And of course, we need to regularly review the evidence. Next, please. Of course, I haven't said, but it's important to note that there could be further waves of COVID. I think all the virological advice is that there will be, and we need to be able to respond to that. And we need to keep our eyes on the emerging evidence that there will be regarding COVID-19 over the next while. But just to show here, this is what is happening in the UK. You can see the bounce, the uptick that has happened as centres start to recover, as the donor numbers and the transplant numbers start to recover. And finally, last slide, just to say, what do I think are the keys to a centre being able to open up again? I think one is the priority testing for donors and recipients that I've mentioned, some protected resources, protected against other urgent and delayed elective cases that have been looked at or needs to be looked after in the hospital, a COVID-free area as much as that is possible, and protection for the living donor side, particularly for living donation restart. Those are my personal views, and the document itself I would refer you to for the supporting evidence behind that. That's the end of my presentation. Happy to take any questions. Thank you.
Thank you very much for sharing with us your policies and approaches, John. That was very interesting. I will ask you a quick question, although I know it's something very interesting for everybody. It's about a vaccine. Everybody's talking about a vaccine for COVID-19, and apparently UK is now trialing a vaccine. Would you think that for potential recipients, all transplant candidates should have it in order to be waitlisted?
I don't think we can wait for that. I think patients require to be transplanted ahead of that. I think it is going to be a while. I'm confident that there will be, that some of the promises made regarding the vaccine will be carried through. But also, of course, there's the whole aspect of, even if you take kidney transplantation, never mind the true life-saving transplants, the waiting list patients' reaction to a vaccine, of course, can be very different to the general population. So I think we can't wait for that. We should still develop it and still test in the waiting list patients. But I think we have to get on and look after our patients ahead of that. And those are the principles that I mentioned that I think we need to adhere to to get the programs restarted.
Thank you very much. I really feel very much involved with the presentation that John gave, and was very insightful. Since, of course, we just opened our program, and indeed we are struggling to find the COVID-19 free areas. So I really appreciate this insight into the UK situation. And now moving towards Italy, where our last speaker, last but not the least, Giuseppe Feltrin, that is the regional transplant coordinator for Veneto region, so very close to you, Lucrezia, and is as well a DTCO board member in ESOT, that will talk about public health surveillance and outbreak investigation for COVID-19.
Thank you. Good evening, everybody. I just start with a very sad picture of Venice in this moment of COVID pandemic. And Venice is the way to help me, let you understand where I come from. I come from Veneto, where that you see is situated in the northeastern part of Italy. And we suffered most of the part of this pandemic outbreak together with the surrounding regions. You see these data which are of the 29th of April, and you see we had a total cases of 200,000 patients with over 70,000 patients who died. And you see that the most part of the cases were concentrated in the northern part of Italy. Next slide, please. Just to give you an idea of what we did in terms of public health, I want to present to you some data from my regional health network. Veneto is a region of around 5 million inhabitants with a density of 270 inhabitants per square kilometer. The mean age is 45 years. The mean life expectancy is 84 years. We have 10 public microbiology labs and 9 departments of public health prevention medicines. These were crucial in our strategy to defeat and to COVID-19 pandemic. Of course, we can say that Veneto is a region at high risk for imported disease. We have tourism, you remember Venice, but also Verona. We have international commerce, and we have the international airport of Venice. Next slide, please. So our strategy divided into 2 main streams. We adopted a strategy for the patients who needed hospitalization, and for those patients who were COVID positive but who could be treated at home in the territory. For hospitals, we decided to promptly convert some of our hospitals into acute and post-acute COVID centers. We almost doubled the number of our ICU beds. We transferred all the non-COVID patients to smaller community hospitals, and we decided from the beginning not to stop transplantation at all, but try to create safe corridors for transplant recipients. Indeed, we have a small hold on the living donor kidney transplantation program, which is very well represented here in Veneto. As far as the territory is concerned, or would better say the treatment of COVID patients out of hospital, we widened the definition of contacts very early. We started with an active program of contact tracing with an early and wide use of swabs. We proposed the quarantine, isolation, and treatment at home for positive patients who were followed up by daily phone calls and by mobile medical teams when needed. In this way, we were able to contain the number of COVID-19 positive patients below 25% of the total patients that we had. And this was a key way to limiting the personal and the nosocomial infection spread. Next slide. This is a 2-day snapshot of the situation in Veneto. In the link below, you see the database where everybody can look at this data in any moment. And I want to point out the fact that, as you can see, we had an important outbreak here in Veneto with over 18,000 patients who were SARS-CoV positive. We had 528 total deaths, of which 1,194 happened during a hospitalization. Can you go back, please? Yeah. Positively, I want to notice the fact that we have over 9,000 patients that fully recovered in this moment, and we still have 100 patients in the ICU in this moment. As you can see, the vast majority of the patients who were affected were of male gender. Next slide. This is the daily trend of some patient categories, and as you can see, we have patients who died, patients who were admitted to ICU, patients who were hospitalized, both in acute subintensive therapies and both in general wards, and the number of patients who recovered from COVID. Next slide. This slide is to show you the distribution of age distribution of patients who were admitted to the ICUs in our region. And as you can see, the most part of the patients who are now in intensive care are aged over 65 to 74 years of age. And if you look at the total percentage of patients who died in our ICU, you see that the most part is represented by patients older than 75 years of age. Next slide. As I told you before, we were very active in contact tracing, so we performed a very huge number of swabs. You can see that at the moment we have now 359,949 total swabs performed with a weekly average of 30,000 swabs performed. In red, you can also see the number of weekly positivity to COVID-19 that we found in our swabs. Next slide. This is a slide just to show you and to study the interface between organ donation and ICU admission because of COVID. You have to consider that at the peak of the pandemic here in Veneto, we had 360 ICU beds occupied by COVID-19 patients out of the 520 total beds that we have. And as you can see, in the first month after the beginning of the pandemic, we have a dramatic drop in the number of organ donation. But you can see that in the last month, we have almost recovered our standard performance in terms of weekly donors assessed. Next slide. The same trend, when we move to the national scenario, can be seen in Italy. Here you can see the drop that we had in donors and thus in transplantation by the end of February, and now we are going back. We can count a drop of around 25% of the donors that we assessed last year in the same period, which is an important percentage, of course, but which is far better than the drop that other European countries experienced in the same period. Next slide. Of course, our competent authority, the National Transplantation Center, gave us some guidelines concerning the safety both of donors and of recipient. This is the measures that we adopted for donors. In the next slide, please, you see the measure adopted for recipients. Next slide. Just to point out the fact that at the moment we have decided to use bronchoalveolar lavage for all potential cadaveric donors that must be performed at maximum of 48 hours before donor harvesting. I want to show you this very interesting data about the outbreak of COVID in transplant recipients, and I have to thank Dr. Massimo Cardillo, of the the director of the National Transplantation Center, who gave me the opportunity to present this data. You see the numbers of COVID-19 positive patients in the general population compared to the patients who were transplant recipients. So you see that the transplant recipients are only 0.3% of the total patients who were affected by COVID-19. Also here you can clearly see a higher percentage of male patients affected by COVID-19, no differences in terms of mean age when compared to general population. On the right side, you see the organs who were affected, the number of organ recipients who were affected by COVID-19. Next slide. In this slide, always coming from this national survey, I show you the cumulative incidence of SARS-CoV-2 infection by type of organ transplantation. And as expected, we have the highest percentage in lung transplant recipients, with the lowest percentage in liver transplant recipients. These data are quite in keeping with the data of the other panelists that we have seen before my presentation. Next slide. Okay, some information about outcomes, and you see the mortality. Of course, we are still analyzing the causes of mortality, but you can see that the death rate was almost double in transplant recipients than in the general population. And the transplant recipients died being younger than the general population. Next slide, my conclusions. Okay, in a pandemic, a community rather than a patient-centered assistant can be an efficient tool for general population. Conversely, in transplant patients, a patient-centered approach is the key to success. Careful donor and recipient screening protocols and the usage of safe corridor for transplant recipients are warmly recommended. I want to conclude, say that COVID-19 infection involved the transplant recipients with a lower incidence in liver transplant and higher mortality rates than in the normal population. Thank you so much.
Fantastic. Thank you very much, Giuseppe. And now, since time is running out, I'd like to open to the floor. I have a first question from Peter Nicholson that I acknowledge for his presence. Thank you very much, Peter, for joining us. This is directed to Eric. So Eric, I'd like to ask directly to you. So in comparing that in dialysis versus kidney transplant, is this risk adjusted for patient comorbidities, and for the dialysis patient, was this confined to those patients who were actually on the wait list, they were healthy enough to be considered for transplant, rather than considering all dialysis patients, many of which are not healthy enough to be transplanted?
That's a very good question. Thank you. For my own theory, it is not adjusted. We have a limited number of patients and it's difficult to adjust on it. But looking at the French Registry, we can say that, of course, the patient on the waiting list or transplanted already are younger. And we have a very surprising result. I didn't talk about this, but on the waiting list, we had a higher rate of mortality, at least declared in the registry. And I think it's, this percentage will have to be checked in the future, because we don't know exactly what it means. But of course, at the end, we will have to adjust for all comorbidities and for age to know whether there is a higher risk in transplanted patient or in dialysis patient. What we found now with the crude data is that probably in transplanted patient, whether they are younger, in better health condition and so on, the rate of mortality seems to be lower.
Thank you very much, Eric. There is a question for Professor Forsythe. John, the question is, in the management of these COVID-19 free pathways and COVID-19 free areas, what do you think is the role for staff testing, for doing the swab or the serology to the staff?
Yeah, it's an interesting point. I think one of the factors that I think is very important to the units having either able to expand their practice or reopening is having a COVID-free area. And I think unless you have the capacity to check staff and make sure that they are not asymptomatic patients with COVID, then I think it's going to be very difficult to make sure that you do continue to have a COVID-free area. So I think if you are setting up, you should think about the way in which you are going to treat staff, and obviously a reminder that anyone with any symptoms needs to be tested, and perhaps a regular testing for staff members within the area that you are trying to designate as a COVID green or COVID free area.
Yeah, that's actually what we are doing every other week. And there are two similar questions for Stefan that I cannot see, but I'm sure that Stefan is still there, okay? So they would like to know how you follow your recent transplants patients during the pandemic.
So we put the transplant outpatient clinic on hold, or we reduced it to the very urgent cases during this core period. And now we're gradually increasing the traffic in the outpatient clinic again, according to the urgency and the need of these patients. Actually, overlapping condition that we need to take into consideration is the overall traffic in the waiting area. So that was the limiting factor, where we thought we can only have so many patients at a point in time in the waiting area. So we adopted the number of patients seen accordingly, and we even more clearly defined the time slot. We advised patients not to appear any earlier than 5 minutes just prior to the appointment.
Okay, so I would like to unmute some of our attendees. Sofia Kalogeropoulou, can you ask your question? Okay, maybe Sofia is not. Then there is another one, Kunal Yadav. You are unmuted now. Can you ask your question?
Yes, hello. This is Kunal from Cleveland, US. So I had a couple of questions for Dr. Rondeau. So the first was, are you guys testing all donors and recipients for COVID, for kidney transplants or liver transplants? The second question I had was, so what if you have a donor who has sort of signs of COVID, but the swab is negative? Now, as we know, the nasopharyngeal swab has a 30% false negative rate. So in that case, are there chances that we might miss a donor who has COVID? The last question I had was, have you been more conservative with transplants now in the era of COVID? Because are you only accepting sort of the more like more DVDs, like Dr. Forsythe said in the UK? Are you accepting more DVD donors compared to DCDs and more sort of standard criteria donor kidneys compared to extended ones? Thank you.
Okay, thank you for the question. I didn't understand very well the first one. I will answer the second and the third. About patients who presented with the signs, clinical signs, but negative swab. Of course, we consider the CT scan, which is a very good element at the initial phase. And in that case, we also keep the patient usually either at home if we don't have critical signs, or in the hospital, and we repeat the swab to see whether it becomes positive. And you're right, in about 30% of the case, if there is no sign of upper respiratory tract infection, the swab may be negative at the beginning, but usually the CT scan can be positive in these patients. Concerning the program of transplantation, it is always a stop in France for now, at least for kidney transplantation, both for living donors and deceased donors. But we expect to start again, and maybe next week or in 2 weeks. So I hope we will have the guidelines and we can use this. And of course, both donor and recipients will have to be tested before transplantation.
Okay, I think we are unfortunately in the wrap up. I would like to thank all of our speakers for their exceptional insights into different realities. I would like also to thank our attendees and to ask them to post the questions that unfortunately were not possible to be answered. There are lots coming. This will be answered in our forum where there is a dedicated thread. So until the next one, I hope you will all stay healthy and safe, and I'll give you an appointment to the next webinar on COVID-19. Thank you very much.
Okay, thank you. Bye-bye.
Thank you for being with us. Good afternoon.
Thank
Bye.
you.